Hello, everyone, and thank you for attending our panel. I'd like to again reintroduce Paul Black, the CEO of Allscripts, and today we'll be talking about healthcare of the future. I love that topic.
I do too.
So I want to start by just, again, asking you to introduce yourself a little bit to the audience and share with us a current project or initiative that you're working on.
Sure. Thank you. Paul Black, CEO of Allscripts. Allscripts is a publicly traded company. We'll do a little bit over $2 billion of revenue in the 2018 timeframe. We're the third largest in the country, second largest publicly traded. And we do a lot of different things, 5 different things fundamentally: electronic medical records, we do population health systems, we do precision medicine, we do post-acute care, and we also do this thing that's called consumer. So you've heard a lot about that today, all these different initiatives that you guys are all looking at and have been talked about today. So from my perspective, as I lead the company, I worry about a couple things. One, I worry about not being relevant to you folks, to you providers, the people that are caring for patients each and every day. Northwell is a great client of ours. It's our largest client, and want to thank Michael for inviting me specifically to be here today, because it's certainly an honor. But the way that I think about being relevant to Northwell is to make sure that we are not only building and doing really well with electronic medical records, but what else is it that they are investing in? What else are they working on that would be important for us to be at the same place or potentially a couple steps ahead of them over a period of time? So I would say the thing that we're working on is something's been talked about a lot today, which is the thing called precision medicine. And to me, I've always apologized to any caregiver in the room who provides care for patients, because you've taken the Hippocratic Oath. You've spent thousands of hours going through medical school training, fellowships, post-bac, all that work that you do. You practice precision medicine each and every day. My father is a pharmacist. He absolutely worked on precision medicine because everybody understands the impact of giving the wrong dose to the wrong person at the wrong time. So with that caveat, when I talk about precision medicine, I thought Dr. Rothman said it in a very nice way. The measurement system will increase in its efficacy and will increase in its ability to get very clear about what I am inside of me and how I'm going to metabolize a certain protocol or how I'm going to metabolize a certain chemo regimen as compared to how it might work for you. There are over 67,000 orderable procedures today. If I'm a physician and I'm logging on to an EMR and I'm looking for a genomic test, 67,000 of those that exist today. So what we are doing, apologize for a long-winded answer to your question, is trying to take the phenotypic information that exists inside of electronic medical record and the genomic information that will come back from a gene panel, merge those two together to give a better answer to a very busy suite of clinicians that are out there trying to take care of patients, to help direct them, not cookbook, but direct them to what the right answers would be for that particular patient. We also, using that methodology, would surveil the population and say, you actually have patients that should be sequenced that haven't been sequenced based on the condition that they have. Not dissimilar to what we heard earlier from Dr. Brennan about 1% of the people actually are on the right suite of medications based on the certain diagnosis that they have. So when people talk about precision medicine, some people jump to sequencing, and I always say stop. Who should be sequenced? Even though the price of sequencing has come down substantially and will continue to do so over a long period of time to make it extraordinarily affordable, it is who should be sequenced given the resources that you have. And we'll also try to point folks and give the average clinician the ability to say, this patient sitting in front of you actually should have a 2-panel gene test in order to determine which one of these medications you're going to put them on will have the most efficacy for that particular person. So that's what we're working on, that we're pretty excited about. And we've got some great pilots that are going on with some really prestigious organizations where we're getting some great results.
Great. One of the things that you mentioned that Northwell and Mr. Dowling are particularly interested in is holistic health, right? Looking at the mind and the body, combining that approach. How do you plan to incorporate that into your company?
Well, as Michael talked about earlier this morning, there's their integration that they have with regard to the ambulatory, the inpatient settings that they have, but also the post-acute care, behavioral health, and the other organizations that they have. I think that universal capability that they possess will enable them to have a better chance to be able to take care of the patient who also has a behavioral health condition, who also may have a substance abuse issue, who also may be depressed. And we all know that folks who also have those conditions will respond differently to the protocols that you've been prescribed to. Your adherence to that protocol will vary depending upon which one of those other behavioral or mental or substance abuse issues that you might particularly have. So their capability and the way that they have engineered, if you will, his health system to incorporate that as part of what they do, I think is very unique in the industry. I get to travel around and meet a lot of CEOs and do business with a lot of integrated delivery networks, large multi-group specialty practices, and the ability for them to connect that data with the clinicians, with the patient at the center, I think is a very unique and important approach.
What are some of the current trends that you see shaping your industry?
The regulatory environment has subsided a bit, which is good for both of us. And by that I mean there was a lot of really good work that was done early on around meaningful use. And from my perspective, probably selfishly, the Stimulus Act was good for America from my perspective from the standpoint that the rest of the population of caregivers that did not have an electronic ways of entering information now do. So it started out with a carrot, ended up being a stick, but the entire platform inside this country is now digital. And when you think about that, it's the first time that's ever happened in the history of this country. And when you think about that, you have all this data, the mega data, all this information that's out there, which can be a burden, but I consider that to be a very high-class problem. The second thing that's out there, once you have this all the data that are out there, 492 different electronic medical records were approved by the Office of the National Coordinator, by ONC, you could buy from them and you would get reimbursed by the federal government. So voila, we have this problem called interoperability. Well, it came from the fact that you have all these different electronic medical records that are out there. It's 2018. We will solve that interoperability problem. We don't need a new government regulation. The folks like us who lead with our chin on being open allow that data to be accessed and to be pulled out and appropriately with the right kind of conditions. But that environment, that chassis, to use a word that was used earlier today, is an extraordinarily important one for all the entrepreneurs in this room, because people that understand that can understand the fact that you now have a playground, if you will, of an immense amount of data that are out there that you can do research, you can study things, you can actually build companies on top of that. And if you're doing business with Allscripts, we actually have an application developer program that will allow you to access our installed base and access our clients. So from a trend standpoint, the ability and just the capabilities that exist today that didn't exist even 5 years ago with the vast nature of connected communities is huge. And the people that are smart about how they put systems together, and I'm talking about IT systems or apps, will have a great opportunity to have an impact to really help people make better decisions, whether that's a consumer making decisions about which one of these venues of care that I want to go see. Do I want to go to CVS, or do I want to go to Northwell? Where do I want to go first based on the condition I have? Do I want to gen up and get a televisit first? All of those things will exist that didn't exist for a long period of time. And I think that these are all extraordinarily important trends that have completely changed the landscape of how consumers will interact with health systems and how clinicians will interact with their patients.
So in terms of the landscape, as you look out over the next 3 to 5 years, 10 to 15 years, what do you see in the short and long term?
I think in the short term, you'll see this industry is, at least in what I'm doing in the healthcare information technology, is going through a bit of a transformation with regard to what has happened with insurance and what's happened with pharma and what's happened with distribution, and that there will be 3 or 4 players that end up being that have the scale to really be relevant over the long period of time. So in our industry, you had these 492 electronic medical record suppliers. That will continue to dwindle down. It'll consolidate, and there will be anywhere from 5 to 10. There are actually only 10 today that have over $300 million of revenue or greater. And so if you will, the haves and the have-nots will continue to coalesce. And I think that at the end of the day, there will be 3 to 4 of us that are out there that will be there. So that is a big piece from my perspective of running and operating Allscripts, of how we play our cards, and from a strategy standpoint going forward. We want to use the ocean analogy from Dr. Josh earlier today. We want to be somebody who is surviving. We don't want to be the plankton.
So one of the things that interests me is how we preserve the personalization of medicine in an age where everything is becoming digital and electronic.
Yeah.
How do you see us preserving that, as one of the other speakers mentioned, sacred doctor-patient relationship?
If I had the answer perfected, I'd be doing something different probably. But here's what I think about that. There is no question that there is a very sacred, trusted relationship, trust being the operative word, between the physician and the patient. I do, however, think that the Marcus Welby MD that many of us grew up on when we only had 3 channels to watch when we were children, that concept of that physician has changed a bit. You talk about the children that are out there, this has become their Dr. Welby. So they trust this for everything else in their life, and we all have to understand the relationship between this device and this with regard to the consumer that's out there. And for us to over-rotate on a longevity of the trust between the physician and the patient, I think is something we have to be very, very careful of. So brand and brand management, what Northwell's done with their brand, I think is pretty important. And I think that people need to understand that who your constituents are. My wife has breast cancer. Her primary care physician used to be the OBGYN. It's now her oncologist. That's who she texts 8 times a day when she's feeling bad, or she has thinks that something's wrong. And he's wonderful at responding to her. If I have a trajectory like my father and I end up having prostate cancer, my primary care physician will become my urologist. So that trusted relationship exists also based on what your conditions are at a certain period of time. So, but there's no question that trust will remain. I think that so building systems, or building that with the concept in mind. So trust has to do with reliability. When I text you, or when I try to get a hold of you, are you responsive? Do I get accurate information? Can I do something like this very quickly on both sides? And when I call you, are you available? So that's why the telemedicine and some of the other things that are out there are also extraordinarily important. The other side of that is the clinician. And what we've done by giving them all these systems, by giving them all this data, we got a lot of burnout and physician fatigue, or this new concept around physician health. And so for the first time ever, based on what I said earlier, you've got the entire population, almost the entire population of physicians that are using computers for the first time, and I'll just say it, they don't all love them. And they're doing things that they felt they didn't go to medical school to go do. They're doing a lot more typing. They're staring at the screen versus talking to the patient. And that they do not like that. So there's a crescendo of discontent that's getting louder and louder with regard to the clinicians that don't really actually like using this. They're not practicing at the top of their license, and they are starting to say, fix that, Mr. Allscripts, fix that, Ms. Epic, fix that, Mr. Cerner. And the people on our side that fix that the soonest will be the best. That has a lot to do with what data do I present to them. That has a lot to do with the AI and some of the other machine learning. But I'm telling you that a brand new or a different type of electronic medical record will have to be built that will take advantage of these data that are out there and that are harmonized and organized, that have the complete medical record, not just the medical record that exists inside of Northwell. You want to have the convergence of the Northwell and the retail that's out there, the Northwell and the behavioral health that's out there inside the Northwell system. But there are multiple different systems that have to be brought together in order to say, where has Paul Black been over the last 12 months and what systems are out there? Doctors want to be presented with data that have already been researched. They would like to be presented with data that thinks the same way that they think, And based on their specialty practice, they would like to have a bunch of that information already presented to them, if you will. The data crawlers have already gone through and looked for all the information about me and bring it back, versus I'm hunting and pecking and looking for my op notes, the other notes, something help in the ED. That's what these white guys want. That's what they want to see. We're working on that project with Northwell, and we expect to get a pretty different type of electronic medical record experience for that clinician over the next 3 to 5 years. It's a pretty exciting and different approach to this marketplace.
I think that's really important. I mean, I can remember in training, one of the first things we learned was to do a chart review to really understand the person that you're about to see. And that makes it personal. When you can say to Paul,
Yep.
I know your behavioral health history. I read it. I know this, and so many times patients come to us and we don't have their whole picture. And it doesn't feel personal in that case. So anything that makes it easier,
Yep.
I think will connect the physician better to the patient.
Yeah, it's you've all, everybody in this room has had this experience. My cousin of mine, she's a nun. I went to go see her with her to her visit at Ohio State University. They have a really fancy, great EMR. The first 3 people that came and talked to her didn't look at the computer. They didn't actually use it, and they were actually talking to her about her condition, which she was scared. She didn't want to be there. Nobody likes to talk about the word cancer. She read a bunch of information. She didn't actually understand the questions about the pre-op visit, and she had to go research it. So when she researched the answers, because she'd very meticulously filled out the forms, that all came back. But to me, it was interesting just watching the caregiver. So the nurse, there are 2 different nurses. There was a resident, and then there was the department head that came in, and they all approached differently. It was great. And she's, knock on wood, she's doing extraordinarily well. But the use of that data and the use of that information that she actually participated very heavily in was an extraordinarily important piece of that, if you will, trusted relationship from my perspective on these guys actually looked at, they've listened to, and they were paying attention to also what I did as a patient to come into that setting. I have, there's, what I love about this industry is everybody cares. Okay, it's very rare to meet somebody that doesn't care about their patient. It is very rare to meet somebody who's an executive of one of these health systems that isn't really a great human being. And there's a lot of passion, which is a wonderful word. We all tell our kids to have passion. It's like, what? Passion is something that's developed over time. And you get to see the passion based on the child that died in your arms, or that, all that happens as a lifelong set of experiences. And what's, I think, great about this and the promise of this is that we have an ability to give these highly trained, highly skilled human beings a better set of tools based on the information and the data that are out there that need to be coalesced and presented in a very important manner so that they can make their decisions based on that data very quickly, versus having to spend a lot of time looking here versus looking at you. And that's going to be a big charge of people like us that are then in this industry, to take all this wonderful stuff. People jump to the Watson, and they jump, but at the end of the day, it's got to be done in a way that is not disruptive or distracting. I call it shouting. You get all this data and you shout at the physician with all this information. They're like, stop. I'm going to turn this thing off because that's not valuable to me, and I want to talk to you about your condition. I want to change that so that they actually go here first and say, excuse me for a second, because I want to get the totality and the recommendations, at least according to this thing. I'm still going to make my own independent decision based on my conversations with you.
One of the metrics of success that you and I talked about that was interesting was happiness. Can
Yes.
you share with us a little of your thoughts about happiness?
Well, thank you. I've always been the whole thing that we have, even in this thing called the Declaration of Independence, around the unalienable rights of life, liberty, and the pursuit of happiness. And so I've always been struck by that word, and everybody knows when you're happy and everybody knows when you're not happy. We talk about patient experience, we talk about net promoter scores. I just like to dumb it down as saying, are you happy or not? And so we're actually trying, of course, take an algorithmic approach to that. And but seriously, there's countries that actually do. There's a national happiness scale or score. There's a national. The country Dubai has a national happiness minister. The NHS has a person who's in charge of loneliness, which might be the antithesis of happiness. maybe not. But there's a lot of work that's gone on there. But there's actually, so what makes you happy? Access to healthcare, affordability of healthcare, the relationship that you have with your caregiver. Do you know them? But things like that, from my perspective, I want to help try to build some sort of an algorithm. And I don't want to be too brainiac-ish about it, but I want to give people something that they can actually use that's helpful to them to make sure that whatever programs they have in place to go be more effective with their consumers is actually something they can measure and monitor versus how does it feel? How does it feel? To me, feels differently than how it feels to the folks sitting over here versus somebody over there, because of the expectations that you bring to that are different. It's it is, and there's a bunch of different things that you can have in a algorithm that we think, and we're continuing to tweak that to say this process, this outcome should yield this level of happiness, and I just think it's an important component. In there are a lot of soft things, behavioral health, the things that you can't control. So anybody that's actually studied this is going to side with me of it. That's difficult, but I also think it's something that's worth pursuing, and I'm pretty excited about that being another venue of what we can potentially bring to the table. Is these systems that drive these processes will yield these types of outcomes with this set of variances, but this set of variances should still be inside of the realm of what is an irritant to, or try to make somebody more interested in working with you versus somebody else.
Great. Thank you so much. I think we may be out of time.
We are.
Okay. So thank you. Thank you.
Thank you very much, Tara. Thank you.